This program is brought to you by Emory University.
All right, good morning. Welcome to Emory Cardiology Grand Round. It is my pleasure to introduce my former mentor, Dr. Anita Deswal, who currently is the Chief of Cardiology at MD Anderson Cancer Center. She did her undergrad medical school and IM residency back in India, subsequently completed internal medicine residency and cardiology fellowship at University of Pittsburgh, and came over to Baylor for advanced heart failure fellowship, and she stayed on faculty at Baylor College of Medicine, and she was the Chief of Cardiology at VA DeBakey Medical Center at Houston, Texas. Dr. Deswal has been recipient of several national and international awards and recognitions, including Master Clinician Lifetime Award at Baylor College of Medicine, Excellence in Clinical Teaching, and Presidential Award for Excellence in Education at Baylor College of Medicine as well. She has been a PI for over 20 clinical trials. She has been reviewer for several journals, including New England Journal, JAG, and Circulation. She has published over 200 articles, and she has given over 50 national and international talks. She has mentored and inspired dozens of medical students, residents, and fellows, including myself back in the day, and she truly is an amazing role model and a very inspirational mentor. Thank you for being here, Dr. Deswal.
Good morning, and thank you for inviting me here. It's really a pleasure, and as I was telling Dr. Taylor, my daughter graduated as an undergraduate from Emory last year, so it feels really weird to come here and not have to go visit her, or not having the pleasure to go visit her, but thank you again. So as I was thinking about what to talk about, let me get my slides going. There has been a lot of excitement in the field of diabetes and heart failure over the last probably decade. And it's, every day you wake up and you see something, there's some new trial or some news article about diabetes and heart failure. So it seemed a very appropriate topic to talk about. And what we'll go through today first is just the epidemiology of diabetes and heart failure, review the impact of diabetes and its control on heart failure outcomes, and then examine the really huge, vast amount of data summarized into a few slides on the treatment of patients with diabetes and heart failure. And it was a couple of years ago when we were on the committee for the heart failure committee for the American Heart Association, and we were charged with writing this statement given the vast amount of data coming out in this field. And even since this came out in 2019, I think there's already areas of it or parts of it that are outdated. So don't think I have to tell the folks here, but burden of heart failure has been high, is increasing still, and every American who's past 40 has a 1 in 5 chance of developing heart failure at some point during their lifetime. And the number of cases of heart failure, of course, keep increasing. And as we've gotten better and better treating other conditions in cardiology, including those with coronary disease, hypertension, et cetera, I think we're seeing heart failure is the final end result, and we keep seeing it increase. And if we think about diabetes, and the darker colors means more, clearly over the years, the incidence of diabetes and the prevalence of diabetes has increased. The same thing with obesity. And these two often go hand in hand as we think about major risk factors for the development of heart failure, such that we have about 30 million Americans who have diabetes, which is almost 10% of the US population, and 40% of the US adults are obese. And if we think about the incidence of heart failure in those with and without diabetes, across several epidemiological cohorts, you can see that there's about a twofold increase in the incidence of heart failure in those with diabetes as compared to those without. And this incidence may be somewhat higher in women and in those with pre-existing coronary disease. And even in those that don't have definite diabetes, the hemoglobin A1C has been a predictor of the development of heart failure over the years. And this was just one example. There have been multiple studies, but this was in the ARIC study, where even those without frank diabetes, but with an increasing A1C, the incidence of heart failure over time increased, especially once you consider those over an A1C of about 5.5. And this was going back to the UK PDS diabetes cohort and the observational part of the study. Again, as A1C increases in those with diabetes, there is an increased incidence of heart failure or risk for heart failure over time. Of course, not as steep a rise as you see with the microvascular complications, as well as peripheral vascular disease. And some studies have suggested that it's not just the diabetes, but the insulin resistance, whether patients have frank diabetes or not, that actually is the predictor of the development of heart failure. And it's possible that insulin resistance, diabetes, increased plasma glucose are even higher risk factors for the development of heart failure with preserved EF as compared to those with reduced EF. And this is just one summary slide. Again, this is a complex pathophysiology and multiple hypotheses about the development of what we call diabetic cardiomyopathy. And of course, there is coronary artery disease because atherosclerosis increases with diabetes and insulin resistance. But then there are those that without the development of a coronary artery disease still develop heart failure, both heart failure with preserved EF as well as heart failure with reduced EF. And this started back in 1972 when Rubler described 4 cases of, at autopsy of cardiomegaly in patients with diabetes, but without other risk factors. And this has been debated back and forth in the literature whether this entity actually exists. But it is clear that there are several factors, including obesity and its associated inflammation, the deposition of advanced glycation end products, lipotoxicity, hyperinsulinemia, and hyperglycemia that lead to 2 different phenotypes of HFpEF and HFrEF. And if one looks at the prevalence of diabetes in patients that have heart failure versus not, clearly in epidemiological cohorts, the prevalence of diabetes in those with heart failure is much higher as compared to those without heart failure. And if one looks at clinical trials, again, you see diabetes is a very common comorbidity in those with both chronic heart failure, where it's seen in about 1/4 to 1/3 of patients with heart failure having diabetes, and especially those with acute hospitalized heart failure, about 40% have concomitant diabetes. So what about the reverse, heart failure as a risk factor for diabetes? And about 60% of patients with heart failure have insulin resistance. And if one looks at just examples of clinical trials where patients did not have diabetes to begin with, and this was the CHARM trial and with the ARB, as well as emphasis with the eplerenone, the incidence of diabetes was about 21 to 28 per 1,000 patient years of follow-up, which is significantly more than 2-fold higher than seen in the general population. And the predictors of incident diabetes in those with heart failure are some of what we expect: the increased BMI, obesity, smoking, increased blood glucose, increased systolic blood pressure, a longer duration of heart failure, as well as a more advanced heart failure. So how does diabetes impact outcomes in those with heart failure? And this is a summary slide just showing one example of a meta-analysis from a large number of heart failure trials and clinical registries. But if you look at several of the endpoints of death or CV death, hospitalization, or death or heart failure hospitalization, one can see that there is an associated increased risk of these outcomes in patients who are heart failure patients who have diabetes as compared to those that do not have diabetes. And again, this is just an example of what about the risk in patients with HFrEF versus those with HFpEF. And you see the risk, again, both in those with HFpEF as well as HFrEF. And again, the risk of adverse outcomes may be somewhat stronger in those with heart failure with preserved EF as compared to those with heart failure with reduced EF. And again, to point out, the hazards ratio almost 1.5 to 2 times higher in those with diabetes as compared to those without in patients with HFpEF. So what about if diabetes appears as the risk factor for adverse outcomes? Is there a relationship with glycemic control and outcomes in patients with heart failure and diabetes? And this is not looking at just heart failure, but cardiovascular outcomes, and looking back at some of the landmark trials that have looked at more intensive versus less intensive glycemic control, going back to the UK PDS study and then Accord Advance in the VA trial. The gray boxes here are the shorter term, so 5 to 7 year follow-up, whereas the light blue boxes represent the late or the really long-term follow-up. And there's no doubt that glycemic control or more intensive glycemic control appears to be associated with better microvascular outcomes, so those of nephropathy, retinopathy, et cetera. But when you look at macrovascular outcomes and cardiovascular outcomes, in the shorter, relatively shorter time, 5, 7 years, there doesn't appear to be an impact of more intensive glycemic control as compared to less intensive. However, in some of the trials on long-term follow-up, there appears to be a benefit on reduction of myocardial infarction and thus somewhat in diabetes. Whereas in some of the trials, like the Accord trial, more intensive glycemic control was actually associated with increased mortality. And then putting this again together in a meta-analysis of these trials, if one looks at more intensive versus less intensive glycemic control, maybe a benefit or somewhat of a benefit in reducing myocardial infarction, not as much in the other outcomes, including if we were to break down the heart failure outcomes, really spot on the hazard ratio of 1, which is intensive therapy didn't appear to pan out in a reduction of heart failure outcomes. And then several observational studies in patients who have existing heart failure. This was just one example. There are several others where we looked at patients in the VA who had existing diabetes and heart failure and looked at HbA1c at baseline and how that would predict outcomes. And most studies have suggested this U-shaped correlation with mortality. So there seems to be this sweeter spot of 7 to 8 A1C where patients appear to do better with increased mortality at both the worst increasing A1C and the much lower A1Cs. Of course, this is an observational cohort, not the clinical trials. And so based on all this data, when we were writing the AHA statement on glycemic control in patients with heart failure, the question was, what do we recommend to the patients? And there is not one clear answer, not one answer that fits all, but it is that you have to look at the rest of the patient, as we do in medicine. And those that are probably relatively younger, with earlier in their diabetes, haven't had the macrovascular or the microvascular complications and appear to have a good prognosis, you may push towards more intensive control of 6.5 or under 7. But those with the majority of our patients with stage C heart failure who have a number of comorbidities or are going towards the more advanced stage, we may think of 7 to 8. And those with very advanced heart failure with poor life expectancy or a huge comorbidity burden, you may even consider 8 to 8.5 as the goal. You don't want to push it too much more. And then to this big volume of data on what about therapies for diabetes in patients who are at risk to develop heart failure and those that actually have heart failure. And again, there has been a boom of clinical trials over the last 10 years or so after the data with the TZDs and what we saw with increased heart failure. The FDA mandated that all diabetes trials with new agents have to demonstrate that the CV outcomes are not increased with the therapy. So there have been huge number of patients enrolled in these trials and looking at, initially, it was just looking at the MACE. So cardiovascular death, non-fatal MI, non-fatal stroke. That was where people were focusing on. Till a few years later, it became apparent that heart failure was the missing element in a number of these trials, and several of the more recent trials have actually looked at heart failure as an endpoint, often though as a secondary endpoint. So going back, and I'm going to just take you through several of the therapies for diabetes. This is with the biguanides or with metformin. And there is no large randomized clinical trial that looked at CV outcomes in patients with heart failure, diabetes, or even patients at risk for cardiovascular disease who were just put on metformin versus placebo. So a large body of the literature evaluating the use of metformin in patients with heart failure and diabetes is observational. And that is the best data we have right now. And numerous studies, including one we had done from the VA, have demonstrated that maybe there's about a 20% lower hazard of mortality with the use of metformin versus all other therapies for diabetes in patients with heart failure and diabetes. Again, this is an observational study or an observational meta-analysis. So the residual confounding could still be present, and maybe we're just selecting healthier patients that receive metformin in that group with heart failure and diabetes. But that is what we have thus far. And given all this data, initially metformin by the FDA had been regulated as being contraindicated in heart failure. And finally, several years ago, it was changed, that the labeling was changed, that now it's not contraindicated and we are able to use it. What about sulfonylureas? Again, not too many clinical trials looking prospectively at the use of sulfonylureas in patients with heart failure, but observational data had suggested that compared to metformin, sulfonylurea may increase the risk of adverse outcomes in patients with heart failure. And actually, there's the warning that lists, to be cautious with the use of these agents in patients with heart failure. However, recently, finally, we have at least one prospective clinical trial, Carmelina, which was just reported out last October. And here they compared patients with, this was not patients with heart failure, but actually patients just with risk for cardiovascular disease. And they looked at glamparide, which is sulfonylurea, comparing it to a DPP-4 inhibitor, linaglaptin, which hasn't shown to have adverse effects in heart failure. And just 4.5% of this population at baseline had heart failure. They demonstrated there was no difference in the MACE outcomes of cardiovascular death, non-fatal MI or non-fatal stroke, or heart failure outcomes between these two agents. So at least comparing it to an agent that in a different trial was shown to be relatively safe in patients with heart failure, you have data that sulfonylureas may not increase risk. Again, going back that the observational studies can be confounded by indication. And then, of course, TZDs, we don't have large randomized clinical trials in patients with heart failure looking at TZDs, but a couple of the trials, the RECORD trial and then the PROACTIVE trial that looked at a high cardiovascular risk population had demonstrated an increased risk of developing heart failure while on the TZDs. And then there were smaller observational studies or smaller clinical trials that demonstrated increased volume overload in patients with heart failure who were treated with TZDs. And right now there is a black box warning for the use of these agents in patients with heart failure, especially being contraindicated in class 3 and 4 heart failure. What about insulin, something that has been used over the years? And again, observational studies had suggested that insulin in patients with heart failure and diabetes was associated with adverse outcomes. And the question was, yes, insulin does cause some weight gain, may cause some volume retention, but is it just that the sickest patients get insulin after they've exhausted other therapies, or is insulin really associated with an increased risk? And we have one large randomized clinical trial in patients with cardiovascular disease that did not show adverse outcomes as far as heart failure when treated with insulin. Again, class 3-4 heart failure was excluded in this trial, and we don't know how many patients at baseline actually had heart failure. That data was not collected. But overall, we have something that shows that insulin does not increase MACE or heart failure outcomes in a high cardiovascular disease population, which is reassuring. And then moving on to the newer agents. So there's the two secretagogues, or one of them being the DPP-4 inhibitors. And what the trials and the meta-analysis looking at these trials with these agents demonstrated that these agents were neutral as far as the MACE outcomes, didn't cause overall benefit or overall harm. But when looking at heart failure hospitalization, again, this is patients with increased cardiovascular risk or existing cardiovascular disease, not necessarily heart failure trials. But there was a difference between the agents. So saxagliptin was associated with an increased incidence of heart failure hospitalizations. And alogliptin trended to, but did not quite make it statistically significant increased risk, whereas sitagliptin and linagliptin were not associated with any increased risk of heart failure. So what do we do with this data that some of the agents may have an increased risk of heart failure and some not? And we actually have a smaller trial in heart failure patients. It was called the VIVID trial, which looked at another DPP-4 inhibitor, vitagliptin. And unfortunately, in the small trial, 250 patients, their endpoint was looking at change in LVEF at 1 year. What they found was the LVEF didn't change between the groups, but those on the DPP-4 inhibitor actually had an increase in LV systolic and diastolic volumes. So again, somewhat one has to be cautious in the use of these agents in patients with pre-existing heart failure based on the data we have. And then the GLP-1 or the glucagon protein receptor agonist trials. And again, you can see there's been a flurry of trials with different agents. And here, this slide just demonstrates looking at the MACE outcomes as well as the individual endpoints that may make up the MACE. And in these trials, about 10 to 23% of the patients had heart failure at baseline. So again, these are not heart failure trials, but in a high cardiovascular disease population, the good news was there didn't seem to be adverse effects on MACE. Several of them were neutral. Some of them suggested benefit on the MACE, including liraglutide, semaglutide, and albiglutide. And when then one looked at heart failure outcomes in these trials and put it together in a meta-analysis, I think the overall good news was, although the meta-analysis suggested there may be a 9% benefit in heart failure hospitalizations with the agent, it was driven mainly by this one agent with albiglutide. Overall, good news, didn't increase heart failure outcomes. So relatively safe in that cardiovascular disease population. But then we had two smaller trials in patients with existing heart failure. So one was the FIGHT trial, which we were part of as part of done through the NIH Heart Failure Network. And in this trial, liraglutide, so one of the GLP-1 agonists, was compared to placebo on top of other therapy for heart failure in patients who were discharged after heart failure hospitalization. So patients with more advanced class 3, class 4 heart failure. And overall, in this small trial, no significant difference in death over the relatively shorter follow-up of 6 months. But when one looked at time to death or heart failure rehospitalization, although this was not statistically significant, the trend was towards increased outcomes in patients with heart failure who were treated with the liraglutide. So again, somewhat disconcerting. And then you say maybe it's fluke, maybe the patients had just advanced heart failure, because in the large clinical trials, they seemed to be safe. Then there was another trial, the LIFE trial, which was like the one done with the DPP-4 agonist or DPP-4 inhibitor, where they looked at, again, EF outcomes at 1 year using the GLP-1 receptor agonist liraglutide. And the blue shows the liraglutide, this is the placebo. So if one looked at change in LVEF over 1 year, again, not statistically different, but liraglutide was associated with increased heart rates and increased cardiovascular endpoints. Again, small trial, but raising the specter of whether we need to be cautious with the use of this subgroup with patients with diabetes and heart failure. So till now, some better news, but not great news on the heart failure front with newer agents. And then finally, we come to the SGLT2 inhibitors, which were the new kid on the block till about 5 years ago, but now have really become the exciting agents in patients with diabetes and heart failure. And what do these agents, the sodium glucose co-transporters, do? The SGLT2 are present in the proximal tubule of the kidney, and they help with reabsorption of the glucose in the filtrate. About 90% is absorbed through the effect of the SGLT2, and then about 90% or 10% with SGLT1. And thus, we land up with urine that really doesn't have much glucose or almost no glucose. What the SGLT2 inhibitors do is actually block the SGLT2. Thus, they very powerfully inhibit the glucose reabsorption in the proximal tubule such that you get glycosuria. And this seemed to be the mechanism they were going after when they started using it as an agent in diabetes. What it also does, along with increasing the glucose reabsorption, is it decreases sodium reabsorption. So there is also natriuresis along with the glycosuria. So often patients will have initially some increased diuresis with these agents, and they lose about 2 to 3 kilos. They may hemoconcentrate, and this was again thought to be one of the mechanisms why patients may benefit with heart failure. So the first trial with this group of agents with empagliflozin was the EMPA-REG trial, and this really created a lot of excitement. So here, if you look at their primary endpoint or the MACE endpoint, there was a benefit about 14% overall. Again, this was a trial where patients had baseline cardiovascular disease, but not necessarily heart failure. Heart failure was present only in about 10% of these patients at baseline. But what was most surprising was that there was a 38% risk reduction in cardiovascular death and a 35% reduction in heart failure hospitalization. So somewhat unexpected. And then there was the question, is it all fluke? Are these agents just expensive diuretics? But we don't think diuretics would reduce cardiovascular death. But again, something to think about. Or was it just a fluke in this one trial? But then there came the other trials with canagliflozin in the CANVAS program, dapagliflozin. Again, these were not primarily heart failure trials. These were CVD patients or at risk for CVD. And they had different event rates, which went from the highest event rates in EMPA-REG to the lowest event rates because the population was somewhat less sick as far as CVD disease in the declared TIMI 58. But what you saw was across the board about a third or 33% reduction in heart failure hospitalization rates with this agent. And this was even more impressive than just the MACE outcomes, which were what these trials' primary endpoint was. So you got a reduction in MACE of about 14% with empagliflozin and canaflagocin. Didn't quite see that with Declare-TIMI 58. The thought being that the patients were probably at an earlier stage of disease with the dapagliflozin trial. So the sickest patients, or those with the highest risk, had the most benefits, so sort of most bang for the buck. And also, again, as you see, the renal insufficiency was more prevalent in the EMPA-REG trial as we went down towards the Declare-TIMI 58. And then, interestingly, if one looks at renal outcomes in these trials, you see whether they had established atherosclerotic disease or they were just at risk for atherosclerosis, the renal outcomes were almost halved in patients on the SGLT2 inhibitors. So these seem to be winners across the board. And just going back to remember, these were not patients with heart failure. Majority did not have heart failure in these trials, but we saw that signal of decreased heart failure hospitalization. And the question was, can we make the leap of faith and just start using these in patients with established heart failure, because we're seeing such overwhelming benefit. But having looked at the other trials where we were starting to see some signals of risk in patients who actually have established heart failure with the GLP-1 agonists, et cetera, there was still caution. And based on all the slew of benefits that we saw with these agents, everyone had a hypothesis as to how these agents may benefit. Some people were nihilistic and said these are expensive diuretics, and all they're doing is making patients diurese, and that's why, with the glucosuria and the natriuresis, and that's what's leading to the benefit. But as I mentioned, cardiovascular death as an outcome is quite significant. And there were other thoughts. These are leading to weight reduction. Maybe there's also decreased interstitial volume. Maybe patients are having a decreased afterload with these agents. There's decreased vascular stiffness. And so a lot of hypotheses, some seen with animal studies too. But finally, the proof is in the pudding, what happens when you give them to patients with heart failure. And the DAPA-HF trial, which was reported last year. So this is the latest so far in the large SGLT2 inhibitor trials. This was now randomizing patients with pre-existing heart failure. So finally, a heart failure trial, large trial over about 4,700 patients, and this was looking at hard outcomes in these patients, and they were randomized to either placebo or dapagliflozin and followed. In the trial, the median follow-up was about 18 months. The inclusion criteria are here at the bottom. So this was HFrEF patients, EF less than or equal to 40%, NYHA class 2 to 4. About 2/3 were NYHA class 2 patients, had an elevated NT-proBNP, and the GFR was over 30. So we went down as close to 30 because the earlier FDA recommendations for the use of these agents were a GFR cutoff somewhat higher. So again, going down to 30, but not under 30. And what we saw was benefit, a very significant benefit. In following these patients, the primary outcome was cardiovascular death or heart failure hospitalization, and there was about a 26% reduction in this outcome over a median follow-up of 18 months with a number needed to treat of 21. And again, these patients were on good baseline therapy with ACE, ARB, or ARNI, beta blockers, and aldosterone antagonists. And if one looked at the outcomes of worsening heart failure, again, this seemed to be what drove the majority of the benefit, with a 30% reduction in heart failure hospitalization, or worsening heart failure, which included heart failure hospitalization or urgent heart failure visits requiring IV diuretic therapy. But going back and looking through it carefully, the majority was actually driven by heart failure hospitalization reduction. And then still an 18% reduction in cardiovascular death. So finally, we have an agent that appears to benefit in patients with existing heart failure and has a benefit that seems to go the right direction in all the patients. And again, there was an overall 17% relative risk reduction in all-cause death. And the benefit was seen across subgroups. The interesting part of this trial was patients may have had diabetes or may not even have had diabetes at baseline. So these were sort of all comers with heart failure, and it was about a half-half split, those with diabetes and without. But as you can see, the benefit appeared similar in both those groups. And then they did a post hoc analysis looking at ARNI because there was a question about how the neprilysin and SGLT2 inhibition, et cetera, may interact. But what they found was in that 10% of patients that were on ARNI at baseline, again, the benefit appeared similar. So very reassuring. What happened to some of the other endpoints that we associate with diabetes? So what happened to A1C? Although in other SGLT2 inhibitor trials, in those initial trials starting with Empereg, we saw about a 0.5 to 1% A1C reduction. In this trial, it was only a mean of 0.24, so very nominal reduction. And the other trials have demonstrated there doesn't seem to be an association of how much the A1C is reduced as far as how much benefit you see in the cardiovascular outcomes. And that seemed to be the case here too. Creatinine, it goes up initially just a little bit like ACE inhibitors because it's thought it may reduce hyperfiltration like ACE inhibitors do. And so you see it bump up just slightly and then it plateaus. Hematocrit did go up. And so again, you go back to this theory of is it diuresis with these agents? But what you find is although the benefits of the SGLT2 and outcomes appears to start early, the benefit or the increase in hematocrit really peaks around 4 months after you use it. So it doesn't seem like this explains all of it. We'll have to wait and see if we can figure out what exactly the mechanisms are. Some modest reduction in NT-proBNP, modest weight reduction, and not significant systolic blood pressure reduction in this group of patients, although it was seen with the earlier trials. And then what about adverse events? Because I'm sure, as all of you know, there's been a lot of discussion about frequent UTIs, fungal infections related to these agents when they have a significant diabetes. And then some mention about amputation with canaphlegosin, Fournier's gangrene, non-hyper or euglycemic diabetic ketoacidosis. But what the trial, at least in the closely monitored setting of the clinical trial, none of these adverse events seem to occur more in the SGLT group as compared to the placebo group. So again, reassuring, but often as we take out these therapies to the population at large, we're going to have to be careful as to how this translates into the population when they're not monitored as closely. So this was a nice review written recently by Deepak Bhatt and Dr. Braunwald, and this is looking at how SGLT2s now seem to have evolved over the years. So initially, they were starting in patients with diabetes who either had cardiovascular disease or were just at risk for cardiovascular disease, and we saw the heart failure prevention in that group of patients in the CANVAS, the DECLARE-TIMI, and the Empereg trials. And CREDENCE was a trial where we saw an improvement in renal outcomes with canagliflozin. And now we seem to be moving towards where we're now looking at it in patients who have established heart failure. And at least we have the results of our first trial, the DAPA-HF trial, showing benefit. And there's a number of other studies, including Emperor preserved, Emperor reduced, and define, deliver, et cetera. But basically looking at HFpEF populations and HFrEF populations, and some of these trials will report later this year. So again, everyone is waiting with the bated breath because we have one good clinical trial. What happens if the second one doesn't quite go there? So that will be interesting for the guideline writers. But I think so far it looks promising. And I wanted to put this in perspective of our existing heart failure therapies. So if we think about the main or the cornerstones of therapy in patients with heart failure reduced EF, and here we're looking at the relative risk reduction in mortality. This is the risk reduction in hospitalization. And this is number needed to treat over about 36 months to save one life. And with ACE inhibitors, this number is about 26, much lower with beta blockers, hydralazine isosorbide, and aldo antagonists. When ARNIs or sacubitril valsartan came along, it had, again, a similar benefit on top of ACE inhibitors. So again, if you extrapolate it, again, this is a little bit of fuzzy math because I just took the numbers and extrapolated them to follow up of 36 months. But again, may need about 25 patients on top of those with ACE inhibitors to save one life with an ARNI. And that number for dapagliflozin, if you extrapolate from the median follow-up of 18 months, may be about 21 to save one life. So comparable in that arena. And of course, the risk reduction with heart failure hospitalizations, which is a huge issue in patients with heart failure, is similar in several of these agents. And of course, the Europeans beat us to it again. So late last year, they came out with guidelines on diabetes, prediabetes, and cardiovascular disease and how to treat patients. And I'm going to focus on just the heart failure aspects here. But what they recommended was SGLT2 inhibitors in those where you want to target the population to lower heart failure hospitalization risk. And this was a class 1 recommendation. That means a strong recommendation. And metformin was given a 2A recommendation in patients with heart failure when GFR is over 30. So sort of a lower recommendation as compared to SGLT2, but a lot of the SGLT2 was coming from the large trials that demonstrated a reduction in development of heart failure in those in cardiovascular risk. So for prevention of heart failure, I think we have good data. SGLT2 may be the best. Metformin, we don't have a large randomized trial, and I think that's why we go to a 2A recommendation. But there are certain caveats, and one is that, again, it's at risk for heart failure, and maybe with another trial, we may be able to say even those with existing heart failure, very strong recommendation. But SGLT2 inhibitors also, the GFR has to be over 30, just like metformin, at least at the moment, until we have data from other trials. One of the thoughts is that as renal function gets worse, maybe the effectiveness of these agents is reduced because they do produce, glycosuria, et cetera, which will go down if the renal function is worse, but we have to wait and see. And then what about GLP-1 agonists, where we talked about our concern with liraglutide and those smaller heart failure trials, although overall they didn't seem to increase the risk of heart failure hospitalizations in cardiovascular disease populations. Again, may be considered in those with heart failure, although a 2B means the data is somewhat equivocal there. And especially you may want to caution against using in patients that have been hospitalized recently, like the FIGHT clinical trial population. And again, what about just the DPP-4 inhibitors? Again, 2B recommendation based on our concerns with some of the clinical trials that may suggest some increase in heart failure risk. But here, there may be different agents. And so acetagliptin and linagliptin were the two agents that did not show an increased risk of development of heart failure. So maybe this could be an agent that could be considered lower down, but maybe a possibility in patients with heart failure. But finally, with advanced systolic heart HFrEF, I think insulin remains the best bet, especially if they have renal insufficiency. And TZDs are contraindicated, and then the DPP-4 inhibitors, saxagliptin, which was associated with an increase in heart failure risk, would be relatively contraindicated in this patient population. And then if you look at just what to do with ACE inhibitors, beta blockers, ARBs, et cetera, in patients with diabetes, multiple subgroup analysis looking back at the large clinical trials demonstrate there really is no significant difference as far as efficacy goes between those who have heart failure and diabetes compared to those that don't have diabetes. So I think we should target that population similarly with the use of guideline-based medical therapy, whether they have diabetes or not. Of course, patients with diabetes and heart failure often have renal insufficiency, and you have to be more careful in certain things like MRAs, which may cause a higher risk of hyperkalemia and diabetes, but you monitor the patients closer, but still try to use those agents. And last slide, this was an expert consensus document from the ACC in 2018. that was giving guidance on how to use the anti-diabetic agents in patients with established atherosclerotic disease. So not quite heart failure patients, but I think some of the same principles apply here, that if patients are started on the SGLT2 inhibitors, for example, and if patients have a well-controlled A1C at baseline, you do have to give it some thought as to what to do with those agents, whether you need to reduce the dose of sulfonylureas by about 50% or reduce the basal insulin dose by 20%. So as cardiologists start to prescribe more SGLT2 inhibitors, because we're going to try to use them in those with or without diabetes now, possibly in those with heart failure, I think we have to remember these in those patients with diabetes who are on other therapy and have labile blood sugars, et cetera. We're going to have to learn this if we're going to prescribe these agents. And I was talking to an endocrine colleague of mine last year before DAPA-HF came out, and I said, you know, we're going to be sending you a lot of patients to start on SGLT2 inhibitors. And he's like, let's wait for the clinical trials in heart failure. Maybe we'll be sending you all our patients to start them on SGLT2 inhibitors. So, you know, we're going to have to learn this, I think, as we go along. Maybe we won't be going to the other agents, but we've got to get comfortable with using this agent in the general cardiology population, especially heart failure. Again, we do have to worry about hypovolemia. Initially, there is some diuresis, and just going to have to follow up the patients. Some patients that are labile with orthostatic hypotension, et cetera, we maybe not use these agents or be careful. Educate the patients about the possibility of DKA symptoms in the absence of high blood sugar. So the euglycemic diabetic ketoacidosis, although not seen in DAPA-HF, I think that was, you know, in the clinical trial population, it's always, risk is always contained better. And then monitor renal function, educate them on genital mycotic infections. But we've got to learn this, and I think get ready to prescribe these agents. So in summary, there is an increasing prevalence of diabetes and heart failure, and they often coexist in 30 to 40% of the patients. There's bidirectional association of diabetes and heart failure, so not just that diabetes increases the risk of heart failure. It seems like patients with heart failure have an increased incidence of diabetes. And diabetes is associated with worse health outcomes in patients with heart failure, both in HFrEF and HFpEF. And metformin and SGLT2 inhibitors may be initial choices currently for our patients with type 2 diabetes who are either at risk of heart failure or those with existing heart failure. Of course, we do await further clinical trials in those with heart failure to confirm DAPA-HF results. Again, caveat, so far the data is good for GFRs over 30, where we may not at present be able to use them with a lower GFR. We'll have to keep tuned. One RCT with SGLT2 demonstrated that even patients without diabetes but with heart failure may benefit. Again, this is exciting. Overall, the GLP agonists are mostly neutral for CVOT risk in those at risk for heart failure, but we are a little cautious in those that have existing heart failure based on the small trials. And for somebody that has advanced heart failure and a lot of renal insufficiency, insulin may still be the choice. Thank you, and I'll stop there. Take any questions. Yes, sir.
As I was listening to the discussion about the SGLT2 inhibitors and being given to patients who don't have diabetes and that sort of thing, I was thinking that, you know, we're going to need to take an approach that's more like the French in explaining what medicines do. So in the United States, we explain to patients that they're taking a medicine that lowers their blood pressure or that improves their diabetes or that does these other physiologic things that we're so smart that we learned in medical school about. The French have more of a tendency to say, you take this because it's going to make you live longer, it's going to make you feel better. And that's really the approach that we're going to have to be taking with patients, is that you're taking this beta blocker because it makes it 35% less likely that you're going to die in the next however many years. You're taking this medicine for this reason. The reality is we don't understand how these medicines work very well. So a comment about worsening heart failure and diabetes. I think the outpatient trials show that about 25% of patients have diabetes. The inpatient trials show 40%. In our life study of sacubitril valsartan, I think it's around 60% of patients at one point we're looking at have diabetes. There's some data that suggests that LVAD therapy may actually improve diabetes control.
Right.
So my question is, in these trials with the SGLT2 inhibitors, has there been any correlation with severity of heart failure with the relative reduction or improvement? Or is there any thought that potentially the sicker patients might benefit more or might benefit less from those treatments?
Yeah, and I'm trying to think back as far as DAPA-HF went in their subgroup analysis. I don't remember that there was that differential seen. Of course, about 2/3 of the patients were NYHA class 2. So that is the majority, and I don't think they enrolled the advanced heart failure population. So I think that remains an area definitely, and part of why their A1Cs get better after LVAD is up to debate, because is it that you get their heart failure better, their insulin resistance state gets better, the stress goes down, and they're doing better, so that's why you're seeing it. Or to get the LVADs in, we're doing a better job of getting their diabetes under control. So absolutely great points, and totally with you on the fact that we have to explain this better to our patients as far as outcomes, because even with beta blockers and ACE inhibitors and ARNIs, we face this. The patient says, my blood pressure's good, my heart rate's good, why are you doing this? And I think that's key. Now we should just sit down and say, okay, so we're going to target your blood pressure, but we're also going to target you and your outcome, and these are the agents that reduce mortality, morbidity. Absolutely.
Thank you for a great talk. I have a question about diabetic cardiomyopathy. So is it really different, or is it just microvascular, sort of low coronary flow reserve, and then heart failure?
Yeah, and you're totally correct. So this entity has been questioned. And what Paulus has shown from Europe is they've taken isolated cardiomyocytes and done some studies, especially with HFpEF and HFrEF. And that's where they've come up with that. I think the cardiomyocytes themselves seem to have a different phenotype with more increased passive stiffness and diastolic dysfunction in those that have the HFpEF phenotype. Versus cardiomyocyte loss, apoptosis, decreased contractile reserve in those with HFrEF. Again, I think it's very hard to tease out the comorbidities. How is obesity play into this mechanism? And I think the microvascular disease and reduced reserve definitely plays a role. That goes without saying, but I think there's more to it than just that. That's what the data seems to suggest.
So thanks for a great talk. So as someone who's not in an advanced heart failure clinic, I know we should do this, think about SGLT2 inhibitors, but can we do it? I mean, I'll tell you, most of the patients I take care of for heart failure, the biggest thing we discuss when they come back is the fact that they haven't taken their medicines or their refill rate is bad. And so one of the things I worry is we keep adding on and adding on. Am I going to make non-compliance worse? Because they just sort of throw up their arms and say, gosh, you gave me all this stuff, and now I'm just, I can't keep it straight. I don't know if there's an answer to that, but I'm just sort of my frustration when I'm dealing with, particularly when you get outside of an advanced heart failure clinic where the, maybe the infrastructure is not so robust.
Like the VA.
Yeah.
I spent my life there, so I know exactly what you're talking about, and I think that has been our focus and our thoughts for many years. How can we do this more precisely? Which are the patients going to be benefited? And we've been talking about it for a long time, but haven't quite made a lot of advances there. And whether again we're going to have to go back to look at their risk. and how much we may be benefiting them. Look at their BNPs. Again, I know the trials have not shown out that using it as a guide, but those that are really sick, we still don't know. Are those the people that are going to benefit versus the earlier stages? And what about cost? As I've moved to MD Anderson, I'm less worried about cost because our therapies are like way cheaper than what they use there. But no, you're totally right. I don't have an answer, but great things to think about. And really, how can we subtype our patients to try to narrow these number of medicines down? There's nobody that can take all these meds.
But I think probably as big an issue is that what's happening with the newer medicine, it's become a real pain for us as physicians because we prescribe a medicine, we do our med rec and all that, and then we have no idea whether the patient's actually going to get that medicine. When we prescribe sacubitril valsartan, and it's much better now than it was 3 years ago, but you'd have to tell a patient, stop your ACE inhibitor 36 hours in advance, but I actually don't know if you're going to be able to get this medicine because you may be calling me up and telling me it's going to cost you $400 a month. And the same is with these SGLT2 inhibitors and just not knowing, and then insurance plans change over time. And I really think that that's where the importance of maybe having a greater need for pharmacists in the outpatient setting to help us with that. There are different state regulations around what pharmacists can actually do. I know in North Carolina, the PharmDs can actually up-titrate beta blockers in the clinic and that sort of thing. And in Georgia, it's much more restrictive as far as what they can do. But it's
Except at the VA.
Is that right? Yeah.
Yeah.
Wow. Okay. Cool. Yeah.
Yeah, we had a pharmacist at the VA who I'm trying heavily to recruit into MD Anderson because I think he ran and saved so many patients' lives for exactly this reason. You stop the ACE inhibitor, you write the prescription for the ARNI, but there's some holdup and the patient doesn't get either. So when they come back to see you, they're off their ACE and the ARNI. And these are challenges definitely to be addressed. All right. Thank you.
The preceding program is copyrighted by Emory University.